Go ahead and try that.
Okay.
Hi, everybody. Just give us a few minutes. We're just finishing to sort out some technical issues with the presentation. We'll be with you in a second. Thanks for attending today.
Okay.
Great, perfect.
Perfect.
Okay.
Yeah.
We are live
Hi, everybody.
now.
Just give us a... Okay. So welcome, everybody. Welcome to Congenital Heart Academy. We are very happy to have one more fetal webinar for you guys. Now, Dr. Rima is going to introduce our two great speakers for this evening. Thank you guys for attending. And please take this time and type all of your questions on the Q&A chat box. You have a great opportunity to learn from great speakers today. So please type your questions. They are going to be happy to answer in the end of this webinar. Rima?
Hi, everybody. This is Rima Bader, course organizer, professor of pediatric and fetal cardiology. This is our 20th episode of the Congenital Heart Academy Fetal Series. We're so honored and happy to have Professor Ruben Quintero as a speaker today. And we really don't have to introduce Professor Quintero because he's very well known. We also have another great speaker, Tara Pop, as a pediatric cardiologist. The talk is going to be between Dr. Quintero and Tara, so they will interchange because case-wise, Dr. Quintero is going to introduce some cases that need cooperation between the fetal therapist and the pediatric cardiologist. Dr. Quintero is the master of twin-twin transition, and he also the artist of the therapy, and he is also very well known for too many publications. He's currently the head of the Fetal Institute in Miami, Florida. Professor Quintero, the floor is yours. Thank you.
Well, good morning or good afternoon. Thank you very much, Dr. Bader, for your kind invitation, both for myself and for Dr. Tara Pop, a pediatric cardiologist at Joe DeMaio Children's Hospital here in Miami. The topic of the session that we chose was to discuss some cases, some fetal therapy cases that required the collaboration between fetal therapy and pediatric cardiology. So let me see if I can share the screen. This one here. There we go. See if it moves. If it moves, there we go. I don't know if this is in the way. Let me put it out of here. Okay, so the first case we're going to discuss is a patient that presented with stage 4 TTTS. This is a 34-year-old lady who was seen in a Central American country. She was diagnosed at 20 weeks with stage 4 TTTS. She had an anterior placenta. You can see here the ultrasound picture with the massive amount of polyhydramnios that she had present. And these are some of the salient images of that case. Here's the recipient twin with polyhydramnios, ascites, scalp edema. And here are some of the Doppler studies with pulsatile umbilical venous flow. The donor, meanwhile, is completely stuck to the anterior wall. It had appeared to have reverse flow in the ductus venosus and no visible bladder. So this lady from South America was desperately trying to see if anybody could help her with this. And what she was offered was to just end the entire pregnancy, or actually to sacrifice this recipient twin. So here you can see the surgery that we did. These are the anastomoses that we found. This is the membrane, the dividing membrane. Here's the donor on this side, the recipient on this side. You can see the connecting vessels here, how the anastomoses can be seen. Again, this is an anterior placenta, but again, the technology that we have allows us to identify these vessels very clearly. So here's a little clip of that surgery, just to show how that's done. You can see here, here's the dividing membrane. Here are the connecting vessels. And once we identify the connecting vessels, and we go ahead and occlude them so that we can eliminate the condition altogether. So again, just to show what is. I'm calling out the anastomosis. You can see here, this is the side of the recipient. I don't know if you can see my pointer. Here's the side of the recipient, and this is the side of the donor. So here's the divided membrane. Anyway, so this is the pre-op Dopplers of the umbilical vein at 20 weeks and 2 days. This is 5 days later at 21 weeks. You can see the improvement in the umbilical vein. And here you can see the donor twin who had absent end-diastolic velocity in the umbilical artery prior to the surgery at 20 weeks. And then at 21 weeks has normal diastolic flow. You can see here also in the donor twin, no visible bladder before the surgery and a visible bladder 5 days after the surgery. So this is the summary of this patient now at 33 weeks and 1 day. What we noticed was, in fact, that the recipient twin, and this is from the pediatric cardiology evaluation, had significant regurgitation, tricuspid valve regurgitation, as you can see here. The donor, on the other hand, had no Doppler abnormalities. Let's see if it's actually placed here, but it's okay. We don't have to. There you go. You can see there. You appreciate those better than we do. So that was the recipient twin. So the recipient twin, who cleared completely the hydrops, is no longer hydropic, nonetheless had significant tricuspid valve regurgitation, and the assessment of pediatric cardiology, was that this baby needed further care and further assessment. These are the babies born essentially at term at 37 weeks and no issues. But again, the recipient having the tricuspid valve regurgitation. So I thought that this would be an interesting case to share with you, and then have the comments of pediatric cardiology on how a case that presents with twin-twin transfusion syndrome, in addition to having cleared the issue surgically with the connections at the level of the placenta, can nonetheless continue to have cardiac issues, and how those issues need to be followed by pediatric cardiology. So let me hand over the microphone to Dr. Pop regarding this case.
Okay, so, as a fetal cardiologist, my role in the case of monochorionic twin gestation in general is, first of all, to confirm normal fetal cardiac structure of the heart. Obviously, Dr. Quintero is very well adept to do that on his own, but I do think that's something that we need to visit in any of these cases. The risk for congenital heart disease is greatly increased from that of a singleton pregnancy with monochorionic gestations. It's approximately 6%. And the most common lesions are ventricular septal defects, followed by right ventricular outflow tract obstruction, atrial septal defects, coarctation of the aorta, and aortic stenosis. And
Tara, you're not sharing your screen. Okay, thank you.
Can you see it? Okay. So the risk for congenital heart disease in monochorionic twin gestations increases in the setting of twin-to-twin transfusion syndrome to an estimated 9%. The recipient in twin transfusion syndrome is the one who's most at risk for cardiac anomalies. And even at early Quintero staging, there can be evidence of cardiomegaly, ventricular hypertrophy, decreased function, and AV valve regurgitation. This risk increases with higher stages of Quintero staging. The risk of right ventricular outflow tract is most marked in stages 3 and 4 and beyond. And it does appear that if we do selective laser therapy early enough, that we can actually prevent that outcome. Okay, so this is our recipient here, as was briefly shown. And I actually met this patient when she was closer to delivery, because she came to our institution at that time for delivery. And as we can see here, there is cardiomegaly, but this is after the procedures that were done by Dr. Quintero, and we no longer see the high drops. The tricuspid valve, if you can see there, is thickened. And as was mentioned, there was severe tricuspid valve regurgitation. She did also have a small mid-muscular ventricular septal defect, but she did not have RVOT obstruction. Here we see the pulmonary valve all the way through the ductus and the RVOT, that's all nice and open. The risk with the donor actually is most increased for coarctation of the aorta. This patient did not have that. In fact, the donor twin had essentially normal intracardiac anatomy. There was an increased echogenic focus here, most likely just benign calcification of the mitral valve apparatus. There was normal biventricular size and function, a little bit of pulmonary insufficiency that I'm not showing here. And this is actually that baby after birth. And we can see normal cardiac structure and function. Going back to the recipient, this is day of life 1. So again, we see the thickened tricuspid valve, the right ventricular hypertrophy, and on color Doppler, you can appreciate the severe tricuspid regurgitation. We also were able to confirm a small little mid-muscular ventricular septal defect. This patient, by the time she actually went home, was doing quite well. That both babies actually left at a corrected gestational age of 36 weeks and 2 days. They progressed quite well, especially when you hear the history of the recipient and the concerns that were there earlier in the pregnancy. It's really remarkable. She did have some pulmonary hypertension for which she continues to be followed for, as well as tricuspid regurgitation, but is growing and thriving. And I will give it back to you, Dr. Quintero, for the next.
Okay, so let's move on to the next case.
Dr. Quintero, do you prefer the questions to be after each case or in the middle or at the end? Or what is the because it's interesting. So what, you and Tara, what do you prefer?
Maybe leave it to the end because maybe we mentioned something along the presentation that can clarify one of the questions, or, you know, they may have more interesting questions as we go along. So
Okay.
maybe we'll leave it for the end. Yeah.
Yeah, sure. Thank you.
Okay, so the next case is a case of monoamniotic twins that we managed with amnio reduction. This is a 29-year-old gravida 1 para 0 with monoamniotic twins. She already had increased amniotic fluid volume, max vertical pocket of 7.3 centimeters when she presented to us. Both babies looked anatomically normal. The growth was still adequate, 46% in one and 23rd percentile in the other, with a 9% discordance. However, we already saw cord entanglement at the presentation. This was approximately at 16 weeks with intermittent absent end-diastolic velocity in the umbilical artery and what appeared to be an AA anastomosis. So here you see the diagnosis of monoamniotic twins. There's no dividing membrane between the fetuses. You can see here on color Doppler and 3D the cord entanglement, significant cord entanglement already present at 16 weeks and 5 days. So this patient went to another institution, and she was told to end the pregnancy because at 16 weeks and 5 days, with this kind of presentation, it was very unlikely that she would have a good outcome. Here you can see the intermittent absent end-diastolic velocity in the umbilical artery of this fetus of twin B. This is what it looked like at 17 weeks and 2 days. She came to us, and we decided to offer her a medical amnio reduction in order to decrease the amniotic fluid volume in the common sac, so that whatever cord entanglement was present would not be enough to result in death of one or both babies. And here's the identification of the AA anastomosis. So the use of medical amnioreduction with Sulindac has been reported for a while now, since 1997. The idea here is that the medication, this is not able to close off the ductus arteriosus. However, it is enough to produce decreased fetal urination.
Jerry, could you please share your screen?
Oh, I'm not sharing my screen at all?
No, no.
Oh, that's not good.
No, that we could, if we could go back to the beginning to show the images, please.
Sorry. I thought I was sharing. Okay. All right. So going back, this is a patient that presents at about 16 weeks of gestation with monoamniotic twins. Here you can see the cord entanglement that was present. You can see that on color and 3D ultrasound. Significant cord entanglement at 16 weeks and 5 days. Here you see some of the Doppler studies with absent, intermittent absent end-diastolic velocity in one of the fetuses in twin B. Significant, again, Doppler abnormalities in the umbilical cord of twin B. So what we proposed to her, she was offered to end the entire pregnancy, or to actually tie and cut the cord of one of these babies. Instead, what we offered her was medical amnioreduction. So this medical amnioreduction, which has been published since 1997, basically consists of the administration of Sulindac as a non-steroidal anti-inflammatory agent that can reduce fetal urination by reducing renal glomerular filtration rate, but not associated with closure of the ductus arteriosus, as is seen, for example, with other non-steroidal anti-inflammatory agents. So in this graph, you can see what happened with the amniotic fluid volume. This is the dose of Sulindac. We started at a dose of 400 milligrams twice a day. And we tailor that dose depending on the maximum vertical packet. You can see here, this is the maximum vertical packet that she started with, and how we reduce our packet. If we reduce the dose of Sulindac, we see how the packet continues to increase. So we can actually see the inverse relationship between the dose of the medication and the amniotic fluid volume. And this is now the diameter of the ductus arteriosus in twin A and diameter of ductus arteriosus in twin B. And you can see here that they never closed. In fact, we kept them open throughout the entire pregnancy by tailoring the amount of Sulindac. And you can also see an inverse relationship between the dose of Sulindac and the size of the ductus arteriosus. So the lower the dose of Sulindac in yellow, the larger the diameter of the ductus arteriosus of those fetuses. We finally admitted her close to 29 weeks and kept on the using the Sulindac. However, at 29 weeks, the fluid started going up again. We actually did a physical amnioreduction with an amniocentesis. We took off 1.2 liters of fluid. And then finally, close to 31 weeks, there were abnormalities in the fetal heart rate tracing, and we went ahead and delivered them. Baby A was 1,600 grams, baby B 1,500 grams. It was only about a 4% discordance. And both babies today are alive and well and doing extremely well. So the issue that we face is the potential death of these babies from being in the same sac from cord entanglement. And we know that this occurs in about half of the monoamniotic twin pregnancies. And that the way to predict clinically if there's a significant knot, if the knot in the umbilical cord is significant enough to kill them, can be somewhat predicted with ultrasound. So what we did in this particular issue is a computer model of an umbilical cord knot. And for this, we took all of the physiologic parameters that are involved in blood flow through the umbilical arteries, and we created an artificial constriction in the computer model, as you can see here on this slide. And then we did a Doppler simulation of Doppler measurements after the constriction created in the blood flow in the computer. And what you can see here is that the closer you are to the obstruction, the more you're going to see these vortices that develop right after the obstruction. And when we correlate that with what the Doppler signal would look like, you can see that this is the explanation for the diastolic notching that is seen when we Doppler the umbilical cords at the level of the knot in the ultrasound examination. Now, the reason that this slide is important is because you need to sample the umbilical cord in various areas. If you sample very close to the tighter portion of the knot, you will see the Doppler alteration. If you sample the umbilical cord far away from the knot, even though there is a tight knot, you may actually miss the diastolic notching. You may actually miss the diagnosis of the problem. So here you have, in another case, a patient at 31 weeks where we can see the diastolic notching that correlates with the computer model that shows that this is indeed a very tight knot. And this is in another case where you can see what this Doppler signal correlates to in real life with a very, very tight umbilical cord knot. So let me stop right here and pass it off to Dr. Pop about her comments on these cases.
Okay, so when we're talking about maternal use of NSAID therapy when it cannot be avoided during the pregnancy, it's necessary for us to follow by means of fetal echo evidence of developing constriction of the ductus arteriosus. The patency of the ductus arteriosus is maintained during gestation by circulating prostaglandins, and NSAIDs work to inhibit the conversion of various prostaglandins, and that can lead to premature constriction of the ductus arteriosus during pregnancy. Ductal constriction leads to increased right ventricular afterload, which can then lead to elevated RV pressure, RV systolic dysfunction, tricuspid regurgitation, pulmonary insufficiency, and then the resulting increase in transatrial right to left shunting to the left side of the heart and or the increased pulmonary blood flow can also lead to left ventricular volume overload and dysfunction as well. And the ultimate end can be fetal hydrops, intrauterine demise, or for those that do survive, they are increased risk for postnatal pulmonary hypertension. When NSAID therapy can be discontinued or when we're seeing some progression and we stop it, typically it does resolve, although unfortunately we cannot predict those that it will not. And the risk is dependent on both dosage and gestational age. We know that after 24 weeks, the risk is increased, and especially once you get up towards 32 weeks. The quantitative indices that we found most useful in determining evolving ductal constriction are the peak systolic and peak diastolic velocities in the ductal arch, as well as the pulsatility index. While the overall shape of the ductus arteriosus with more of a hourglass appearance can be indicative, really measurements of the ductus arteriosus can be difficult. And this is also after birth when we're trying to, because there's a lot of variation in where you measure the ductus arteriosus. So you can almost make that number what you want, and it's very hard to make sure that you're following the same spot over time. The picture on the right here demonstrates an evolving constriction of the ductus. Up here is actually a normal velocity. Over time with constriction, you start to see increase in the systolic velocities and then increase in the diastolic velocity down here. And this was one of our patients that we shared, and this patient, luckily, despite maternal therapy with Soldeneck, was able to tolerate it. We followed her very closely, and we had a very nice Doppler pattern. And here with color, we can see nice flow through the ductus arteriosus. I'm going to give it back to you, Dr. Quintero.
Okay, well, thank you very much, Dr. Pop. Let me see if I can share the screen again. Here we go. This is the screen. Okay, so the last case we're going to talk about is a case of rhabdomyoma. And I have a little clip here that hopefully explains the whole case. So you can see this is a patient that's a 19-year-old gravida 1 that was presented to us at 28 weeks. Ultrasound showed non-immune hydrops with a very large cardiac tumor and small lungs. This is the ultrasound image on presentation at 28 weeks. So this patient was being followed at an outside facility. We were contacted when she was now being sent to the hospital for delivery. So the baby had a right-sided cardiac tumor, about 4 centimeters in diameter, with a pericardial effusion. So what we did here, first of all, we diagnosed that the baby had anemia by ultrasound by measurement of the middle cerebral artery peak systolic velocity. And because of the large pleural effusion and the small lungs, we went ahead and placed a thoracoamniotic shunt. This is the recording of that procedure. Actually, this baby had a pericardial effusion, not pleural effusion. And the effusion itself was not serosanguinous as is typically seen, but actually a hemopericardium. There was blood just coming out of the chest of the baby. So we had to do a couple of transfusions more, and ultimately the patient was delivered by cesarean section almost at 33 weeks. These are some of the images of the cardiac surgery. It was very difficult surgery for the cardiac surgeons. Had to do 2 surgeries actually to remove the tumor entirely from the baby. But here are some images of the closed heart. And here's some surgical pathology of the tumor, which was a rhabdomyoma, and this is the child at 1 year of age. So the presentation was that of non-immune hydros with all of the features of non-immune hydros, a very large mass, polyhydramnios of 34 centimeters fluid, very, very small lungs, and again, Doppler findings suggestive of fetal anemia. Here again, more clips of that ultrasound on presentation. This is the fetal echo, but I'll let perhaps Dr. Pop talk about the fetal echo in more detail. So the first cortisthesis showed a hemoglobin of 11.4, so not that severely anemic as predicted by the peak systolic velocity of the middle cerebral artery. In other words, with a peak systolic velocity of 2.08, you would expect much lower hematocrit. But nonetheless, we went ahead and gave the baby the transfusion. To bring this up, we did the thoracoamniotic shunt with a hemopericardium, and we also did an amnio drainage at that time. She had a repeat transfusion at of 45 cc's when the MCA rose to 1.69. The hemoglobin at the beginning was 10.4 and at the end was 13.3. We also did an amnio drainage. The thoracoamniotic shunt actually became dislodged at about 30 weeks and a half, but it did not recur. The pericardial effusion did not recur. We had to do another amnio drainage because she had a very short cervix. In a max vertical pocket of 15, we brought it down to 7.8. We gave her steroids, and again, she delivered at 32 weeks. So the sterilization was done for breech presentation, no other reason. Here's the postnatal course with resection of the cardiac mass on day 2 of life, had an ileostomy for a terminal ileal perforation. On day 28, so about a month later, had resection of residual tumor. The ileostomy was taken down 3 months later, and the path again showed rhabdomyoma. The genetics was negative for tuberous sclerosis. So an example of expectant, aggressive, invasive management of a fetus with rhabdomyoma. So this woman was sent for delivery at 28 weeks, and we managed to take this case all the way to almost 33 weeks.
Okay, so when we're talking about cardiac masses, as demonstrated in this case of the rhabdomyoma, our job is to characterize the mass as much as possible. And we can do that based on the location and some certain defining characteristics of the mass itself. The increasing availability of fetal cardiac MRI will also be advantageous to that effect. We did not unfortunately have that at that time, but we will actually very soon have that here. We want to determine whether this is a solitary lesion or if there are additional heart lesions, whether in the heart or elsewhere in the fetus. We also want to determine whether these masses are causing obstruction to any cardiac or extracardiac structures in the fetus as well. Especially with rhabdomyomas, we're concerned about the potential for fetal arrhythmia. Significant effusions can be also involved with any cardiac masses. And rhabdomyomas are the most common fetal cardiac mass, and as depicted here, they typically are homogeneous. However, they're typically more multiple masses and not quite as large, although they do have the characteristic of growing rapidly over time. And we definitely saw that with this mass as we were following it. As was already mentioned, there is the association with tuberous sclerosis. This baby was tested and that was negative. And there's also something that we should talk about, was not done in this case, but as a fetal cardiologist discussing with the family the potential for using sirolimus as a medical treatment. We obviously have to give it to mom to treat the baby. In this case, the mother declined that therapy, but something else to consider. So So this was at the time of presentation when she first came at 28 weeks. And as was mentioned, there was hydrops here, very large mass, and it was compressing the right ventricle, especially the outflow tract, considerably. And after having the fetal interventions, this was actually the last fetal echo that was done prior to her delivery. And this was at 32 weeks, and we can see that the fluid has really resolved. The mass has gotten larger in the interim. And here we can see that compression on the right side of the heart. This is what it looked like immediately postnatally. So we can see that the right ventricular cavity is really being compressed by the mass. And even into, as it circles back around, we also see some narrowing of the LVOT here as well, because it was just so large. And here from another view. There was a CTA that was performed prior to going to surgery, and again, to demonstrate just really how large this mass was in comparison to the baby's actual heart. And this was the resected mass from that first surgery, which again was almost as large as the heart itself. So he did have a bit of a protracted course, as was mentioned. But this is the baby, actually a follow-up of at 3 months of age. And as we can see, the heart is not completely normal. There's, especially when you look at the tricuspid valve, some redundancy to the leaflets. They're still not coapting, but improved from prenatally. There's still RVH. And the tricuspid regurgitation was still there, however, was greatly improved from before. This baby is continuing to thrive as an outpatient, as you saw in the picture. I'll get back to you, Dr. Quintero.
Okay, well, Rima, these were the cases that we wanted to discuss with you today. As you can see, the theme here is how we need to work literally hand in hand with the pediatric cardiology and pediatric cardiovascular surgeons, actually, in this case, this last case, very, very seamlessly, so that we can have the good outcomes that we can actually report, today. The very first case with the twin transfusion syndrome, again, was told to end the pregnancy, to abort. This was, impossible, stage 4. This was And instead, this woman goes home back to Guatemala with two babies. Yes, they still have to be followed by pediatric cardiology, but again, we could, offer some help to this lady. In the second case, we were able to avoid altogether having to end the pregnancy, and we managed to keep these babies from, performing a very, very tight umbilical cord knot. And in the third case, which was actually sent for delivery with hydrops at 28 weeks, which would have been a neonatal demise, on the spot, we managed with all of these different procedures to, take this pregnancy literally 1 month later, remove entirely the pericardial effusion, and then give the pediatric cardiovascular surgeon a chance to tackle this very, very large tumor, and in fact have the outcome that we have. So an example of how, again, here in Miami, we work together with our pediatric cardiology teams to try to provide the best for these patients.
Thank you so much. Beautiful. Before we open the floor for discussion, Dr. Quintero, could you, and also Tara, for each case, you want to take the take-home message, case by case, please, because getting 3 different topics and 3 different patients is very important. Yet, let's make it simple to the audience. For first case, what is take-home message from Dr. Quintero's point of view and from the fetal cardiologist's point of view?
Well, the first case, the take-home message, there are 2. The first one is that you don't give up on stage 4 TTTS babies, because in our hands, at least, the survival rate of TTTS stage 4 is still upwards of 85, almost 90%, number 1. And number 2, that you always have to wonder if there is something else in addition to the anatomy of the placenta that may be off, that could be explaining the severity of the presentation of the case, as was actually shown here by Dr. Pop, that in fact there was congenital heart disease in the recipient that needed to be followed, subsequently. So that's a message from the
What about
the first case.
gestational age? Does it play a role?
Well, stage 4 can present at any time. The earlier it presents, the more you suspect that there is something else happening in addition to the placental, issues. But we can do stage 4s literally at any gestational age.
Tara, from the fetal cardiologist's point of view,
I think from a fetal cardiologist, from our standpoint, I would say really is to remember that Dr. Quintero and other fetal interventionalists are there, and to not give up on these patients without, we have very frequent communication. We have group discussions at our surgical conferences, which also involve our cardiac surgeons and all of the cardiologists as part of our practice, and Dr. Quintero, to review these cases. Just recently we had a patient, very complicated, family wanted to do everything. And, it was really Dr. Quintero saying, okay, if I can help this baby with, really large effusions that were there, would you offer her surgery? And, the surgeon's coming back with, well, that's really her only chance. If we can do that. And it was, a rare genetic anomaly and things like that. But that group discussion, I think, is so vital. So remembering that there's something else, we're limited in what we can do just with medicines. And, we all know the pain of watching things progress and losing a fetus that potentially could have had a chance.
Rima,
Thank
one
you.
quick comment.
Yeah, I'm going to say welcome, Dr. Huta, my mentor and my co-author. And
Just
great
one quick comment about twin. Historically, having lived through years of amnioreduction therapy with no selective laser therapy, and then working with Ruben for 10 years and seeing the dramatic change that can occur with this treatment. But I did want to comment that hypertension in the recipient twin is quite a severe problem. Sometimes the pressures are 2 or 3 times normal systemic pressure with hypertrophy and cardiomyopathy, as you showed in that case. And you can relieve that, Ruben, with your treatment. But if it's not relieved and the baby's born in that condition, then the abnormal hormones, which are still circulating in his circulation, can make him very hypertensive immediately postnatally for the first day or 2. And one should consider antihypertensive therapy, nitroprusside therapy, for a day or 2 to obviate what could be an ascending blood pressure. I've seen babies lose their cardiac output entirely with a hypertensive crisis after that problem.
How do you know that there's hypertension in utero? I know.
No, I'm
you
talking
say
about the
that.
postnatal. Well, you do. The
Oh.
TR jet tells you. TR jet tells you exactly what the blood pressure is. It's the same in both ventricles. And so you're monitoring, and you got a 4.5 meter per second jet at 80 blood pressure in a 25 weeker. You know you have severe hypertension. But the point I'm making is that if you take away the communication, that should improve. Part of our job is to be sure that it does improve. If not, then to manage the newborn with frequent blood pressures and managing the first day or two before those hormones clear from their circulation.
Beautiful. Dr. Quintero, do you agree to that? Do you keep that in mind? I know that Dr. Huta always said that. Do you, and also for Tara, do you keep measuring the blood pressure in NICU for those newborns, the recipients particularly, or it's just a missed thing? We will just concentrate on the heart and the stability.
Well, from our point of view, what we have noticed, in fact, and I think Jim also has seen this in cases that we have shared, is that if the baby has, particularly the recipient, has congenital heart disease and is decompensated completely because of the twin-twin interferon syndrome, once you resolve the twin-twin interferon syndrome aspect, meaning once you take care of the excessive volume load that it's getting from across the placenta, that baby improves, even though it has congenital heart disease. So therefore, knowing that the baby does have some structural abnormality in conjunction with the pediatric cardiologist, obviously, it makes us follow that baby, more closely than the cases that typically resolve and nothing else happens. But what Jim is pointing out is that you need to remember that there are other things that could be going on and that do need to be followed up. And that's why Dr. Pab, mentioned, what kind of outcome or what kind of follow-up these babies had to have.
Thank you. Anita, do you have any comments on case one?
I do, thank you. Can you hear me okay?
Yes.
That was, all three of those cases, very, very beautiful. Thank you so much. The comment I had about the first case has to do with acquired congenital heart disease, both pulmonary stenosis and mitral valve disease, which the pulmonary stenosis is very well known, the mitral valve disease a little bit less well known. And I wondered what you thought of the mitral valve postnatally, Tara. It looked to me like the chordae were a little bit shortened and the valve a little bit thickened. And
yeah, no, I definitely agree with that. The valve was not completely normal, although it functioned well. There was really just trace mitral valve regurgitation. The baby definitely requires ongoing follow-up and is going to remain with a cardiologist keeping an eye on all of the heart, but definitely that mitral valve was not completely normal. Now the pulmonary did look normal in this baby.
So
we're talking about the recipient, just for the audience, right? We're talking about the recipient.
Yeah. It's been my experience that, some of these stage 3 and 4 have severe mitral regurgitation and some of them don't. And in probably 10 years ago now, we published from UCSF a series of 4 cases of acquired mitral arcade, so acquired severe mitral valve disease. But this was an autopsy series, so we had no way of knowing what the natural history was after laser. And it seems to me that it's possible that the mitral valve, sort of an arcade look, it's possible that that can actually improve with laser therapy, which is not something that we're trained as pediatric cardiologists. But certainly we see the pulmonary valve disease improve after laser. In the pre-laser era, pulmonary stenosis in recipient twins after twin-twin transfusion was about 10 or 15%. And in the post-laser era, it's closer to 2% in every series that's been published. So I think this is an interesting case of a fetus with mitral regurgitation that survived laser. But The other important thing to know is that if there's severe mitral regurgitation and you already have right heart failure from the hypertension, then you are severely limiting the cardiac output. Whereas if the left ventricle is still healthy and there's no mitral regurgitation, the fetus can redistribute blood flow and stay healthy for a lot longer. So I would just pay attention to the mitral valve in stage 3 and stage 4 twin transfusion. Although, you know, at this point, laser therapy is certainly standard of care. But a nice illustration. Thank you so much for that.
Now,
So you're saying
interesting
that the
thing.
arcade, sorry, Dr. Quintero, so you're saying that the mitral arcade is an acquired disease secondary to the twin transfusion and it will disappear after laser therapy? Anita, is this the message?
The first part, yes, is the message, but the second part is we don't know if it disappears because there hasn't been a natural history study specifically looking at the mitral valve. The Fetal Heart Society is collecting cases now, and the data is in analysis. So we'll have an answer to the second part of your question within the year.
Thank you. Dr.
The
Quintero,
interesting
sorry
thing
for
about
interrupting.
the interesting thing about this case is that the problem here was not the mitral valve. The problem here was the tricuspid valve. And we've seen other patients with dysplastic tricuspid valves that present with stage 4. And then when you do the laser therapy, even though the valve is still dysplastic and there is tricuspid valve regurgitation, the condition of the fetus improves. So again, the message here is, yes, these are treatable, but you need to pay attention to the potential of structural congenital heart disease that needs to be assessed and followed by pediatric cardiology.
Thank you. Any more questions?
Yes,
We don't have questions.
absolutely. The tricuspid valve disease is far more common. Dr. Quintero is quite correct in pointing that out. I think, though, that part of improvement in the tricuspid regurgitation is that the blood pressure that we've been talking about, the blood pressure in the fetus does drop pretty quickly. And in my practice, we see them within 24 hours. And often, not always, often the Dopplers are even a little bit better by that time. But at a week, the predicted blood pressure should be down, and by a month, it should be normal.
Okay. Dr. Fadden, do you have any questions?
Yes, thank you, Dr. Quintero and Dr. Pap. I'm Majid Fadden from Riyadh, Saudi Arabia, as a fetal therapist here. So my question to Prof. Quintero, do you think there is a relation between the morphology of the anastomosis and the severity of the cardiac stress or the cardiac, I call it a stress injury that happened to these patients? Do you see more like the more the AV anastomosis they have or the AA that lead to these traumas or these stress injury to the heart?
That's a very difficult question because obviously the permutations are endless of what types of anastomosis you can find. The most severe cases are those where there are no anastomoses going back from the recipient to the donor. So, and these are very rare. I think less than 1% of placentas will have only anastomosis going from donor to recipient with no anastomosis going back from recipient to donor. So in the usual scenario, what happens is that there are either more or larger anastomoses from donor to recipient, obviously, to cause the disease. But what we're seeing in these cases, and we published this many years ago, is that some cases have either acquired or congenital structural heart disease that may make the twin transfusion syndrome be a facultative development, not an obligatory development. When the anastomoses themselves dictate the development of the disease, they don't have any way out because they're going to have TTDS. But if you look at the anastomoses, and the anastomoses would not necessarily imply that they would develop TTDS, but they have TTDS, and then you realize that one of the babies has congenital heart disease. Once you eliminate the anastomoses, then the congenital heart disease tends to improve. We've also seen that, by the way, in cases where there's an umbilical cord knot in the recipient. So the umbilical cord knot in the recipient is a situation where the recipient cannot return the blood, the excessive amount of blood that is getting from the donor. And if it has an umbilical cord knot, it has no way of balancing out the amount of exchange. So in those cases also, when you eliminate the anastomosis, this baby may actually have a breather, so to speak, and then improve the situation. But to answer your question, it's almost impossible unless you have these very, very rare cases where there are only anastomosis going from donor to recipient and none at all going back from recipient to donor.
Okay, so my understanding that's whenever there is a congenital anomaly, the adaptation to the twin will be worse than the non-congenital. And which congenital anomalies usually think that it attributes to the worse outcome, or the more advanced stages with not that much of anastomosis to make it worse? Is it like
the most
which
common
one?
yeah, the most common one, as was mentioned, is the congenital, either acquired or let's say bona fide original pulmonary stenosis. That's the most common one that we see in the recipient twin.
Okay.
But there can be others, like in this case and in other cases, with tricuspid valve, or that was mentioned about the mitral valve.
So it's like the chicken and the egg, which one came first, to make it worse for them?
Yeah.
I know I can come in here and ask a question, because I think what Dr. Fadden is trying to say is this a physiological finding, the congenital heart disease? But I don't think so. And please correct me, because as Tara said, there's VSDs and whatever in the twins. So is it genetic? Is it molecular? Is it pressure? Is it flow? I don't know. I'll leave the answer to the heroes, Dr. Quintero, Dr. Huta, and Anita, and whoever deals a lot with twin. Why do we have congenital heart disease?
Regardless of, you see, our attitude has been, regardless of what the let's say explanation may be, whether you think it's congenital or acquired, it doesn't matter. They have TTTS. We take care of the TTTS. We take care of the problem. If that baby then improves and everything disappears, you say, okay, this was acquired. If, as in this case, the valve is still damaged and it's still dysplastic and this baby requires, further care, then you say, okay, well, maybe it was not necessarily acquired, although in that case, you still don't have the answer.
Rima, if I could, there was a case series that came out of UCSF a few years ago that attempted to answer your question, whether this is genetic, epigenetic, or acquired due to placental factors or some other factor. And the answer is yes to all of those questions. Tara said that there's an increased risk for structural congenital heart disease in monochorionic twins. And that is absolutely true. Even without twin-twin transfusion, it's about 4.5% will have structural heart disease. And that varies. They could be heterotaxies, which is probably an early epigenetic phenomenon. That can be hypoplastic left heart syndrome and hypoplastic right heart syndrome from valve disease of the aorta or the pulmonary valve that causes progressive hypoplasia of the obstructed side. And of course, as Dr. Quintero said, ASDs, VSDs, and we also mentioned coarctation in the donor. So it's a spectrum and can have potentially many different causes. And the rule is that twins are discordant for the anomaly. So there have been reports of twins with 22q deletion syndrome, where the cardiac manifestations were different in the two twins, one unaffected and the other with, I think, truncus arteriosus. So it's a very fascinating phenomenon in monochorionic twins, this high incidence of all different kinds of congenital heart disease, with presumably identical genetics. Sorry, long-winded answer, but I think it's an interesting point.
It's very interesting. I would also add, Anita, to your if you have
Yeah, the question was not, the comment was not heard, Dr. Bader. Okay, so
I'm sorry. What I'm saying. What I'm saying is that with IVF to expect the incidence of anomalies to increase in monodiag. I mean, as you said, Anita, that there's epigenetic and there are lots of factors. I think if you add IVF to all those factors, then the incidence would be higher of congenital heart disease. I think. I'm not sure.
Well, IVF has an increased risk of monoamnionicity, of monozygosity, of monozygosity, so 3 times larger than or higher than spontaneous conceptions. Whether it also adds to the increased risk of congenital heart disease, obviously they go hand in hand. So anyway.
We have one question from the audience.
Go ahead.
Says in TTS, are all anastomosis superficial, or are there deeper anastomosis that can be reached by laser? And distinct the question to Dr. Quintero. And do you think those can be hemodynamically significant?
Well, this pertains to the treatment, the laser treatment of TTDS. We've answered that question many years ago because the original paradigm or the original conundrum was that there were superficial anastomoses that you could see, but the deep anastomoses you could not see. So we've shown that that's not the case. The placenta doesn't have underground anastomoses that are invisible. The placenta has only anastomoses that you can see on the surface. Whether they connect superficially or whether they connect deep within the parenchyma of the placenta, it doesn't matter because you can all see them at the level of the surface of the placenta. So this notion, I don't know exactly where it came from, and 20 years later or 25 years later, we still can't get rid of it. This notion that you cannot get the deep ones. In fact, we will get up and in meetings say, excuse me, and can you get the deep ones? And say, yes, the deep ones they're all visible. They're not hiding, they're right there in front of you. They connect deep in the placenta, but that doesn't mean that you can't see them. So yeah, any type of anastomosis, is visible at the level of the surface of the placenta.
Okay, for the second case, because we're running short of time, what is the take-home message from Dr. Quintero and Tara?
Well, the take-home message for monoamniotic twins is that, yes, you can offer the patient not to continue the pregnancy. The mortality rate is very high, about 50%. Yes, you can offer them cord occlusion and transection of the umbilical cord of one of the babies. We usually defer that option to cases where they're calling me from everywhere, guys, where one of the babies has an anomaly. So for example, you have a trap sequence monoamniotic, or you have an anencephalic monoamniotic, or you have some other lethal anomaly monoamniotic. Well, in those cases, there is no sense in trying to risk the healthy baby, with Sulindac or something. You just go ahead and tie and cut the umbilical cord of the anomalous fetus. Again, another phone call. But in the case, like in the case that we presented here, where both babies are normal, they look structurally normal, there's nothing wrong with them. It's very, very difficult for a parent to say, okay, well, sacrifice A or sacrifice B. So, and we don't like to do that either. So we give it a shot. We say, okay, if we can reduce the amniotic fluid volume to the levels, as you saw in the graph, where we basically, bring down the polyhydramnios to either a normal or even below normal level of fluid, then we simulate what happens normally in monoamniotic twins after 32 weeks when the amniotic fluid volume decreases spontaneously and they don't have fetal demises after 32 weeks. So this was an example of how, you can achieve that. So the take-home message here is, if both babies are normal and the patient is unwilling to undergo a surgical procedure to tie and cut the umbilical cord of one of the babies, this is an option. Now, you can also lose both babies in trying to do this. We're not saying that this is panacea, that you're going to be successful in all the cases, but this is an option. And sometimes even when they lose the babies, when you try this, they don't feel with it. They don't have the same psychological effect as having purposely decided to end the life of one of their babies. So that's a take-home message.
Tara, anything to add?
I think just from my perspective, just, to continue close collaboration with the fetal interventionist and the cardiologist so that, we can continue to offer these babies that everyone else otherwise would give up on a chance. And by working together, we can help support each other to try to do that.
How
And-
often do you bring them to follow up? What's your protocol?
sorry, what's that?
How often do you bring them back for fetal echo?
Well, that definitely depends on, exactly what we're talking about. It's very different if you're talking about a ductal constriction versus a twin transfusion, right? But I mean, especially in the beginning, we'd be following very closely. You want to be able to watch, see if there's an issue, see how they responded to the first therapy, see if there's a need for additional so that communication can be ongoing. And so, yeah, and unfortunately, there's no easy answer for that. I think it's a case by case, but especially in these very sick fetuses, that would be very frequent in the beginning until you have a good idea of, where we are.
Yeah, I think this is important because people all around the world are listening to us now. We need to give a little bit more guidance. Like, as you said, if the lady's admitted in the hospital, you can do fetal echo whenever you want, right?
Mhm.
But if she's outside and somewhere else, we have to have a plan. So before admission, we have to see her weekly, and then upon decision of intervention, and then post-intervention, how often do you see them? And if you see them postnatal, and probably after the intervention, how long is, and the question goes to Dr. Quintero and Dr. Huta and Anita, how, and of course to Tara as well, after the intervention, when do you expect the improvement of the condition of the heart, the donor and the recipient? Is it a week? Is it 2 weeks? Can we have numbers, please?
It can be rapid, but it's variable based on case, I would say.
Yeah. And well, if you're referring to twin, usually by about a month, everything has pretty much gone back to the way it should be. The hydrops, the polyhydramnios, even some of the Doppler abnormalities. Usually by a month, everything should have resolved. The take-home message for the third case, if I may, because I have to run too. Waiting for me, you see the phone ring, is the following. This was a case that was sent for delivery because they had non-immune hydrops and a very large cardiac mass. And what we did, as Dr. Pop, in fact, explained about another case, where we analyze these problems, is we break the problem into parts. What does this baby have? Well, this baby has non-immune hydrops. The baby has theoretically fetal anemia. The baby has a very large pericardial effusion. Okay, so we're not going to deliver the baby with all these problems and have neonatal demise. Let's break it into pieces. Let's take care of the anemia, we transfuse. Let's take care of the pericardial effusion, we put a shunt. Let's take care of the polyhydramnios, we drain the amniotic fluid. We even put her on Sulindac, for example, if we have to. Let's say in this
the
case.
lungs as much of a chance as we can by getting as far out to term as in the direction as we can.
Exactly. So, we don't have lungs at 28 weeks. This baby's gonna, be a neonatal demise. At 33 weeks, when baby was born, baby has lungs, and the cardiac surgeon can operate on this baby, whereas at 28 weeks it would have had no chance. But again, if you just look at the whole picture, you say it's impossible. What you do here is you break it into parts. Let me take care of the anemia. Let me take care of the pericardial effusion. Let me take care of the polyhydramnios. Let me take care of, the different issues. You just break it into parts. And that way, we managed to take this case a month later so that the cardiac surgeon could have even the opportunity to remove the tumor. So the take-home message is, don't get startled by the presentation. Break it into pieces and see if you can address each of the individual pieces with as few as possible fetal interventions, by the way.
Question, why there is anemia from the audience in the case of rhabdo, fetal anemia?
Oh, this baby was bleeding into the pericardium. So the baby had a hemopericardium.
So hemopericardium. But why was the baby bleeding? This is not very common, is it? That you get hemopericardium. Usually you can get pericardial effusion secondary to the obstruction, but why hemo? Is there some sort of erosion happening or compression to the vessels?
I would have to leave it to the cardiac surgeon. I mean, this was blood. I mean, blood just came out of the pericardium, just pure blood.
It was a very, very large mass too.
Yeah,
so
very large mass. Mm.
And very interesting also, Dr. Quintero, which I don't understand. The genetic testing was negative for tuberous sclerosis.
Yes. They don't have to have tuberous sclerosis. It's associated with, but they don't have to have. In fact, baby had an MRI. There was no evidence of, lesions, intracranial lesions, nothing. The baby does, and genetically, the baby didn't have any evidence.
It's 80% of, they used to say 60% of fetuses with rhabdomyomas will have tuberous sclerosis complex. We've done a paper review at the sick kids and it ended up to be 85% of the fetuses with rhabdo will develop tuberous sclerosis complex. They don't have to have lesions at birth, but the question, I'm probably genetics, not all of them have the gene. And this is also very interesting. What I've learned from you is that you kept monitoring the anemia with the MCA, and you kept, what was the level that you want to keep the MCA velocity, say, okay, I'm not transfusing? Because that was an indirect indication of the anemia, right?
Yes, well, as you know, the MCA has now been used very effectively in the monitoring of fetal anemia, the diagnosis and monitoring of fetal anemia. So 1.5 multiples of the median or greater is suggestive of severe fetal anemia for the first transfusion. For subsequent transfusions, we tend to move that index a little bit higher because the false positive rate increases with each transfusion. So as you saw, we didn't intervene in the second case, exactly at 1.5. We waited until that figure went up higher, and then we did the intervention. So yes,
you're looking at the velocity as well. Once I think the velocity also was there.
Yeah, the peak systolic velocity is what we monitor to determine the likelihood of fetal anemia.
169,
but again,
I think.
you use 1.5 for your first transfusion, even though we don't necessarily intervene at 1.5. We wait a little bit, maybe 1.6 or something. But at the presentation, it was 2.08. And then, we did a second transfusion when it was almost 1.7. So we waited.
And why didn't we use sirolimus here, medical treatment? I know it sounds horrible. It looks very big. I don't think I would do it, but the question comes, what about medical treatment for rhabdo? A lot of people would, because we know that the natural history is that it will regress after some time. And even they gave antenatal and postnatal. Was this considered in this case?
It was considered, and actually the patient herself declined.
Oh, okay.
Yeah.
Okay. And postnatal was very, very complicated surgery as well. I don't know, the ileum, and why did we go through all that? Was it invading all this?
It just shows, these are not straightforward cases. That's why, we don't have all the other colleagues that participate in this case. We have a pediatric cardiovascular surgeon, we have pediatric surgery, we have, a number of colleagues that have to, literally embark on the care of this baby. This is a multidisciplinary, approach to this fetus, to this baby. Otherwise, you can fix this and, you'll still lose a baby from something else. So this is the virtue and then the value of working together with such a large team.
I have a question from the audience. I think you've answered it, but why do TTS fetuses get RVOT obstruction and abnormal TR, tricuspid and mitral valve disease? Is this a volume overload? What is the etiology? This is one question from no name.
Mm-hmm. Well, yeah, we've addressed that again.
So,
we don't know if it's primary or secondary, and in some cases it's very obvious that it's secondary. In some cases it's not so obvious, but regardless, the presentation is such that you need to treat it. You treat it, and then you can decipher, what you think could be the cause for this.
Very simple question.
I don't think we know, but I can suspect that it has something to do with the vasoactive mediators that are elevated in the recipient during the acute phase of the twin transfusion. Endothelin 1 can cause fibrosis, and then you also have the pressure overload and the volume overload when there's valve regurgitation or acceleration across the valve. You're getting continuous endothelial disruption, and if you have a pro-fibrotic agent in high levels, then it may be that sort of fibrosis faster than it normally would, to the point where these valves look identical to congenital abnormalities. So it's probably that, especially since with laser therapy they regress. So definitely it's something, whether it's coming from the placenta or coming from the babies themselves. I don't think we know.
Yeah, again, to answer the question for the audience is that the presentation, when you have the presentation, you take care of the problem, you take care of TDDS, and you know, if things disappear after you've treated the baby with TDDS, then it was secondary to the TDDS. If they don't disappear, I'm gonna have to go, guys. If they don't disappear, then obviously you can suspect, okay, well, this was either primary or it was secondary and it didn't go away. So the only case where you can say that it was physiologic or secondary to a disease is if they do disappear.
I think we can conclude. Dr. Quintero has to go, and we're so grateful for him being with us, and as well as Tara and our eminent panelists. And I would like to thank the audience for staying late, but the whole event will be on the YouTube, and you can watch it anytime.
Thank you so much.